that this number represents. And of course, this data is now going on 7, nearly 8 years old, so could be higher than this. But what's important about this is we've known this for a very long time, and that's not like there hasn't been initiatives to try to um, move the needle on this, and millions of dollars have been invested on this, but in many cases, the programs don't work. And why is that? Some of that we can maybe uncover with some of the discussion today. But also importantly, I think one of the things that is difficult is if we approach this as a national problem, it ignores the fact that there is so much variability um, when we look at regionalization of this work. And that's really been where, over the last several years, I've tended to focus is there is opportunity right now to improve care systems, to make a positive impact on patient health, to drive health-related metrics. Um, but much of that needs to be done, I believe, through local and regional initiatives. And if we're trying to approach this as a national initiative that doesn't take into account these variations regionally, it just makes it more complicated. And I think we will not see some of the returns that we can get if we approached it regionally. So this is where I'm coming from. I feel like I've been a little bit on a crusade for a while with recognizing or trying to discern what would actually move the needle on some of these things. So I've been in my career 27 years, or at least I've been at the University of Minnesota 27 years. Um, I'm sure all of you have observed this too, but for decades we have seen opportunities, we've seen expanded scope of practice, we've seen payment opportunities emerge, but we don't also always see pursuit or adoption with things associated with those opportunities. So that's been frustrating. And in a different presentation, I didn't bring that into this presentation. I have collected many of the examples and the data that shows that there was an opportunity created and there was very little uptake associated with it upon the adoption of that opportunity. I spent 4 years working with a national medication management related collaborative, initially run through HRSA and then ultimately supported by CMS. So that really was an influential period of time and carrying over some of the lessons I learned then still now. That led to the creation of the Alliance for Integrated Medication Management. That was an organization that became the non-governmental venue of attempting to carry on the work that the HRSA and CMS initiatives started. Another influential aspect of my career that has helped inform this was being the co-PI on a national study applying implementation science to comprehensive medication management and working with the joke would be I'm not an implementation scientist, but sometimes I try to play one on TV if anyone's old enough to remember that old commercial. But in that opportunity, I had the chance to work with implementation scientists and understand the discipline a bit better than I had before and why it works. And then more recently, leading regional implementation strategies for pay-for-performance collaboratives uh, with a regional health plan and community pharmacist, doing that in more than one example, but I'll share one specific example today. So to get started and putting this together, I was reminded of a conversation I had with a health plan leader. And this health plan was operating in an area where other health plans had made the decision um, to pay pharmacists for patient care services. Um, Medicaid was already requiring it, so there wasn't a debate there. But some of the other health plans said, well, if we're doing this for Medicaid and we see a value in it, why wouldn't we do this in commercial and in also our Medicare Advantage plans? This health plan had not made that move while others had. So the question was, what would it take for you to do the same? What's different in your case than in the case of the others? And the response was pretty simple. We operate in several states. We don't believe we can engage enough organizations to build a network that will create access for a majority of our beneficiaries. Basically, what they were saying was, we don't believe the pharmacist community will step up. We won't be able to meet the needs of our beneficiaries to the degree that we need to invest in this. And what that highlights is there's a gap. It's a known gap that can occur between policy change and then actually producing the intended outcomes associated with what drove that policy change in the first place. And that's where implementation sits, is in the middle of that. In this case, there had been policy change at the plan level and at the state level in Medicaid that was creating a payment opportunity, but yet at least in this health plan's perspective, implementation had not moved along to the degree where they could rely on it and establish a network that would meet their needs. And so I've come to appreciate, which comes from some of the implementation science work, is that there is a promise that's embedded when a policy change is advocated for. There's a promise that this is what we can deliver, and it could become a reality. And there's the promise in the potential new future, but in many cases we don't necessarily also then get the practice impact. So we have to turn the promise in a policy change into the practice that will then lead to the impact. And so there's that gap that in many cases is a challenge. And this came as an analogy to me that I've used several times to think about this outside of pharmacy, but maybe for us to be thinking about what does it look like in pharmacy. So this is the Oslo Hackney Music Hall in London, on a suburb of London. And when my daughter was a senior in high school, my spouse and I took her to London for a trip. And while we were there, she discovered that one of her favorite bands was going to be playing while we were there in this venue. And this is not a big band. So they weren't necessarily playing a big venue, but she begged and begged and begged and said, can we go see Bad Sons? That was the name of the band. And of course, I drew the short straw. My spouse stayed in the hotel that evening, and I and my daughter traveled out to the outskirts of London to this music hall. And while this band was playing, a band that I was not particularly a fan of, they were playing in a hall that I would say is, take one of your large classrooms in your university, and it wasn't any bigger than that. There was maybe 300 people at this. This band is from Southern California. And I'm sitting there thinking, what is it that's bringing this band from Southern California all the way to London, out into not the core of London, to this suburban area, to this small music hall? Why are they doing that? And I happened to be, because I wasn't really into the band that much and it was kind of empty in the back of the room, I was actually reading articles while the band was playing. And it happened to be diffusion of innovation work. And so it came to me, this band had their music on Spotify, right? Anybody could find this music anywhere, really almost anywhere in the world, but maybe they would find it and maybe they weren't. And this band was traveling, because that's the difference between diffusing and disseminating an innovation. They were creating an experience. They were getting people excited. They were hoping that those 300 some people that were there were going to go the next morning and tell their friends, their colleagues about, you missed this great band. You need to find them on Spotify, to create the social networking that was going to drive the adoption of the Bad Sons sound. So it's this difference between a passive and an active process. And you may be aware, maybe you've read them yourselves, but these are the articles I was reading while this band was playing and making this connection that they were in a very active process, rather than relying on technology to disseminate their sound and hope that people would find it. They were making it happen. Rather than waiting for it to happen, their goal was to make it happen. I'll guess that most here are familiar with the diffusion of innovation curve. But this is the number that we're looking for. The theory is that 16% adoption creates this tipping point. And from that point, then whatever that innovation is has the potential to stick, to become mainstream. And in many cases, we aren't at that 16%. Is it 16% of pharmacists adopting services? Is it 16% of patients who have a need receiving those services? We could define this in a lot of ways, but in most ways, the way we would define it, we're probably not at 16% yet. So the question is, how do we accelerate this movement? We're probably still in this early adopter phase in many cases. Will we reach the early majority, or will we miss this opportunity? And so that's really where I'd like to go, is what does create this acceleration towards the on the incline of the curve of the diffusion of innovation. So the questions, I've got 4 questions interspersed throughout the presentation. This is the first one. A recognized factor that drives diffusion of an innovation is which of these 4? Money and compensation, reducing regulatory barriers, social system for adopters, or goal setting by adopters. And I think that I understand that in many cases in your seminars, you're using the chat to, people can indicate what they believe the answer is. I don't know if this produces any questions at this point, but for the purposes of this presentation, all of these could have a role, but when it comes to diffusion of innovation theory, really the answer is C, a social system that creates connections and builds active processes. And so this is 4 of the drivers of the diffusion of innovation. The innovation itself and how people react to it and what they see as the opportunity, communication channels, how it gets promoted through media to spread knowledge, and time. Is it worth the time on my part to adopt this? What's the ROI associated with that investment? But where, for today, my focus is on this, creating a social system. How we bring people together, share, communicate, inspire, support is an important part of taking innovation and actually getting it to that tipping point. And the question is then, do we let that happen passively, or do we look for the strategies that can do this and prospectively seek to implement them to create that social system with purpose? Again, many here probably have seen the difference. Diffusion is a natural spread of ideas. Dissemination is a conscious effort to spread knowledge, a much more prospective, active process than what diffusion would normally be. And in the work that I've done, I'm bringing these 3 things together: learning and action collaboratives, implementation science, diffusion of innovation, so that it's all about being purposeful, achieving intended results in an accelerated time frame. That's, I think, what we could all agree, that in the opportunity that exists right now, we have to do those 3 things. We have to have purposeful action. We need to achieve the intended results rather than results that are not what was intended, and do this in an accelerated time frame, or we might miss an opportunity. A lot of looking at implementation has looked at it from in an organization. So this is my summary of looking at some of the differences of implementation within an organization versus what's different when we're doing it across a community. It is harder. It is more complicated. And there are strategies, but they're probably less well adopted when we're looking at implementation of an innovation across a community, or in this case, if we were to say across a profession. I won't go through, with the time that we have, all of these specific ideas here. Can make this available afterwards if there's interest. But suffice it to say for this is that the way we approach implementation in an organization is different than the way we need to approach it when we're dealing with a community, and there's a lot of diversity across that community. The strategies then that can actually support that are multiple. And this is my classification, and looking at many of those, organizing them into a variety of different categories. So community organizing, how do we bring the groups together, start to build that social networking opportunity? There's strategies around that. How do we communicate once we've got some sense of organizing around the community? How do we bring that community along? How do we expand its size? How do we communicate around that with purpose? Then into moving into program implementation across the community, but happening in individual organizations. A variety of different strategies that range from determining whether or not an organization is even really ready for this. Is there truly a commitment? Using coaching. Education is something that we do a lot of. It's necessary, but in some ways it is also a fairly passive process. Feedback loops and adaptation to local context. And then finally, last category I've outlined in looking at this is that partner motivation and engagement, how we keep people engaged in this and across, in what we're talking about here, both sides of the equation, the provider side and the payer side. And what are those elements that are going to create the win-win for both so that we have a true partnership and we stay engaged. So back to that concept of turning a policy promise. We've reduced regulatory barriers, we've created payment opportunities, we've expanded scope of practice. How do we make sure that that actually turns into the impact? I think the second part of each of these statements is maybe in cases where we've been, we need to move to the other side, the first side. So we need to be more collaborative than isolated. We need to be more active than passive. We need to be more strategic than random. Can we be more organized rather than relying on individualization across individual organizations? We need to recruit many rather than relying on the few. We need to be committed, truly committed, as opposed to I've been involved with organizations that say they want to do something like this, but they don't really invest in it fully. And then ultimately, to end this is, and I think this is something for me is really important to where we are right now in pharmacy, is it is not necessarily just about finding a mechanism to be paid. We have to be able to do that in a way that creates value. If we generate value, then the payment will follow, the business models will follow. And I'm not sure that that is always the case in some of the ways that some of the initiatives are being approached, that they are in fact more transactional. I do this, pay me this. And it may or may not be what aligns with what a health plan has as its priorities or its pain points. And so how do we generate value while we're doing all of this? So to distill this down into an example, this is a project that we did a few years ago that really brought the practice community and a health plan together to leverage an opportunity that health plan had established, but was not necessarily being taken up by the community, specifically community pharmacy. So Health Partners is a health plan and a service provider organization, HMO-like, open model, but it does not rely only on its own healthcare entities within the organization. It's an open model. Anyone, the network is broader than their own organization. So, but from the health plan standpoint, they are a regional insurer, and they are in the Medicaid, commercial, and Medicare business lines. They had been invested in comprehensive medication management for some time. The pharmacists that were in their healthcare delivery settings in their primary care clinics, the funding for them was actually coming from the health plan, not from the service provider side of the organization. And it was because of the value that they recognized from having that integration. And so this is just a very quick outline of, they've done this multiple times in the organization, but they've done an internal analysis on the ROI of this particular model of practice. And what they found was that there was a return on investment to them as a health plan of 11 to 1. Now, that should be in some context. That level of ROI was within their highest utilizing demographics. If you um, targeted a wider population, they would see a lower return on investment, but it was always positive. But in their highest, most complex, highest utilizing beneficiaries, they saw an 11 to 1 ROI. They repeated the analysis a few years later, same outcome. Now, from an implementation standpoint, some of the things we have to think about that drove that ROI and that we can't ignore as we're trying to expand this. There was a common patient care process. There was a fidelity to that service. They knew what the service delivery was. And that was what they established as what they were paying for. It was very clear in their payment for services that this is the model of what they pay for, and they audit for it. They had face-to-face assessments. They had a competency established of the practitioners. There was service integrated with medical providers, integration with their EMR and population management strategies. Sometimes those things are not necessarily thought about when we say the what drives the value of a pharmacist. The intervention is not the pharmacist. The intervention is the service provided by the pharmacist. And this gets to some of those environmental factors that influence that service that's delivered. And to repeat that outcome of 11 to 1, these things need to be kept in mind. But the health plan said, this is driving value for us. We want to expand this. So they had a fee-for-service payment program in their commercial Medicare Advantage and Medicaid programs. From commercial and Medicare, they built in a performance-based payment structure for related to hypertension and diabetes, specifically blood pressure control and A1C. Tobacco status and beneficiary engagement were the other factors that went into this performance-based model. They had beneficiary attribution, that they would share reports with providers. CPT codes were established, documentation that they needed, actually built a system that lowered the administrative burden for providers, that made it easier. They didn't have to use a proprietary software to submit this. The continuity of care document is what they were able to submit, which provided the information they needed for CMS requirements. But what happened was most of the health systems in our state were participating in this. Community pharmacies were not. And this started back as far as 2006 with Medicaid. Commercial programs were added in 2010, I believe, and Medicare Advantage maybe somewhere around 2012, 2013. This is 2018, we're getting started with this, 2019, and we had seen very little uptake in the region by community pharmacy practitioners. So the health plan said, how do we get them involved? We've got beneficiaries across a wide geographic region. We can't achieve the results we want to achieve based on just those who are currently providing the service. We need a broader network. So they wanted greater beneficiary engagement, but they were not getting the full clinical impact that they believed they could generate. And so the full opportunity of value was not achieved. Again, the policy was there, the policy changed, the payment was there, the impact was not being realized. So that led to what we called slice of pie. PI stands for the Partners in Excellence. That was Health Partners' name for their performance-based payment program. That PI program extends across medicine, dentistry, and they had built this out to include pharmacy as well. These were all the different groups that came together to pull this project, to lead this project. Health Partners, of course, the University of Minnesota was the lead. We had engagement from UNC from an implementation science standpoint. The Alliance for Integrated Medication Management provided coaching and convening support, and then the Medication Management Network of community pharmacies. There were 12 community pharmacy organizations, not 12 community pharmacies, organizations that were part of this. Most of them were not credentialed with this health plan prior to the start of this project. So what we were creating was an 18-month learning collaborative building this all teach, all learn environment. Each organization that participated had an assigned implementation coach. We facilitated pacing events. So these are all the different strategies to drive adoption and accelerate the uptake. We had a number of implementation supports, and there was this payer-provider partnership in that the provider was, or the payer was providing attribution. All the pharmacies would receive attribution lists of individuals who were already patients of their pharmacy, and these were those individuals who were at risk and aligned with those performance-based metrics around hypertension and diabetes. There was a payment available with meeting those metrics, and the organizations knew that they would needed to meet the expectations of the service definition that the health plan was paying for, and there was audits of the documentation. In starting this, and as taking away one of these principles of driving accelerating adoption, you need an aim, a bold aim. And so we set as the goal with all of these pharmacists in these pharmacies that they were going to see 1,000 health partners beneficiaries for an initial and at least one follow-up visit prior to December 31st of 2020. So it was basically a 12-month time frame. It was 18 months in terms of 3 months on the front end, getting things organized, getting people ready, a 12-month period of service delivery and data collection, and then a 3-month period at the end of closing that out. From an implementation evaluation, we were looking specifically at the concepts of penetration, adoption, and fidelity. And I'll share some of the results on each of those implementation outcomes. I'll say now, we did not hit the 1,000 patients. Part of it was December 31st of 2020. You can all probably remember, if we went back 9 months from that date, what happened. This was all done in the middle of the pandemic. Our first 3 months were going great, and then all of a sudden, things were shut down and priorities shifted. But despite that, these organizations stayed committed to this and tried to figure out a way to navigate this while we were in the middle of the pandemic. From an implementation outcome standpoint, looking first at penetration of that group of beneficiaries, there were 1,240 individuals that were specifically attributed to the practice sites. 478 of them had any sort of recording of actually being seen and assessed by a pharmacist. So a little less than 40% actually received some form of service. You can see it broken down here. There was 3 different cohorts. There was the diabetes cohort, there was the cardiovascular disease cohort, and then there was another attributed cohort. And what that was in a broader risk assessment strategy within Health Partners. They were beneficiaries who were deemed high risk, didn't necessarily fall into the diabetes or CBD cohort, and they were also attributed to some of the pharmacies. So it was a pretty low stakes, really, in terms of what they were recording was, did they either have tobacco status recorded, blood pressure measured, and an A1C documented? And you can see, again, disrupted by the pandemic, but it gives an indication of some of the challenges that even outside of the pandemic, this group might have in either getting this information and being able to document it. This is the level of adoption, so the penetration by site within each cohort. A lot of data here. The details aren't really the point of this. What I would highlight is these sections that are squared off. Those were the sites that met their metrics. And this was the celebration at one point when we got through the pandemic, completed the project. These were some of those pharmacists who led that effort in their pharmacies to serve those beneficiaries and met the metrics in the pay-for-performance strategy. And so they were able to be recognized by Health Partners, and they also those pharmacies received performance-based payments on top of the fee-for-service payment they had already received. So there was a success among this group, many of which were not engaged in this work at all prior to this project. And in fact, um, we were a little bit surprised when we got started. We knew that many of them that signed up to be a part of this collaborative were not participating, but we had anticipated that we could kind of start at this point and take them here. And what we quickly found out is we had to go about 3 steps backwards from where we thought we needed to. For example, even though it's available on the Health Partners website and it's not that complicated to become credentialed, very few of these groups knew how to get credentialed at the beginning. So we had to help them with that. And it really was a coaching process. It was a foreign language. It was a new process that they had not experienced before. Um, the documentation, some of them had IT limitations that they weren't able to interface with the health plan. They had to bill through a medical billing process. Their current systems didn't have that. They had to work through that. The submission of the CCD document with the documentation, they had never done that before. And how did they work through that? And they had a lot of questions. Now, the health plan was very supportive of this. They actually have someone on staff who works with the provider network to help answer questions and resolve these things. But there is a limitation to how far they can go. And I don't know the policies about it, but they've said, we can help people learn how to work with us, but we can't tell them how to bill us. And so to some ways, there was a need for an external body to help this group in a way that even though the health plan was as supportive as they could be, it didn't address all of the needs and all of the significant growth in adopting to a very new world that this group was unfamiliar with. And that's where this all of those partners came together, and in particular, the AIM coaching support came into play. So measuring practitioner fidelity to the comprehensive medication management model is important to which of these items. And so the answer to this is D, to ensure that the service is implemented as intended to achieve the same outcomes observed in previous evaluations. Can't leave that to chance. There is a reason why we produced the outcomes we did in a small scale. And if we're going to scale that to a broader scale, we have to ensure that those variables that went into producing those outcomes in the first place are maintained over time. And so this was what the health plan was paying for was comprehensive medication management. This is a resource that describes that care process. And we went through fidelity testing. If anybody's interested in looking at the tool that we used to test fidelity, it's available here, no cost at optimizingmeds.org. There is both a PDF and an online version that you can go through and do a self-assessment associated with this care model. This was the data that came from the initial and then subsequent assessments of were the practitioners actually following that care model. As you can see on that first assessment, there wasn't any one of the 5 domain areas where there was consistency in moving beyond moderate fidelity. With training, with coaching, with peer support, with pacing events, we were able to increase the level of fidelity from baseline over time. But that was very intentional. And it was with the expectation that that was a necessary thing to do for this group to be able to produce an outcome that was similar or at least close to that 11-to-1 based on service model that created it in the first place. In that fidelity assessment, we could also look at that in terms of not just the care model, but how many beneficiaries received an initial assessment and a follow-up. And as you can see, there was a lot lost to follow-up. Initial assessments and then follow-up became less. It was something that the practitioners were not used to, is actually be accountable for a follow-up assessment on something that they needed to determine if the outcome of either a recommendation or a change that they made had actually occurred and produced the outcome they were expecting. Population management, again, there was attribution. To the point of this slide is really looking here. So we did not see a significant clinical outcome difference in this group. And the reason, or in this project, and the reason was if you look at what the baseline was, of those beneficiaries that the pharmacist saw, the vast majority of them were already at goal. Now, these patients were apparently already engaged in their healthcare, um, even though they were attributed in many cases. The health plan didn't have this level of data, and these were the individuals that on pharmacist outreach engaged them. But this is nowhere close to what our state averages are for blood pressure control, A1C, and smoking status. So they were a group that was healthier than the typical beneficiary, and that affected the ability to demonstrate results. So what do we take away from that? Was that in the absence of some of the additional information, maybe the relationships with primary care, the lack of laboratory data, the group that the pharmacists were seeing were not the group they should actually needed to see. Those patients were not engaging them in some way, or they weren't reaching out to them. Again, pandemic, it made it harder to actually create beneficiary engagement, but those who were engaged were not really in the intended target audience. So thinking about what made this all work, most valued implementation strategy from the perception of the collaborative was which of these? And this has happened in our work with AIM over and over again. Coaching is the thing that makes the biggest difference. It's the thing that people appreciate the most. And these are all the different strategies we use, but in assessing from the perspective and perceptions of the providers, what made the most difference to them, it was coaching. It's a time intensive, it's an expensive resource, and that's the challenge in using that. It can produce the best impact, but we have to find the resources to be able to provide it. These other aspects will contribute as well, but our experience has been nothing is more impactful than coaching. Some of it is the customization for the individual practice, but maybe the biggest thing is, and they have described this to us in interviews, it's like having a fitness coach. There's an accountability. If you're going to meet with your fitness coach once a week, you want to have a good answer for what you did for the previous 6 days in terms of improving your health. And it was the same with this. When you're going to meet with your coach every 2 weeks or every month on implementation, did you actually follow through on what you set? So it's about priority setting and having someone who's following up on you is in addition to the actual act of coaching. So the takeaways from this, we did see increased community pharmacy engagement. I'm pleased to say that all of those organizations that were not participating with this health plan prior to this project are currently still involved and probably even expanded beyond what they were able to do during that week. So we did accelerate the adoption. As I mentioned, we overestimated some of the readiness, and we had to step back and provide a lot of support we hadn't originally anticipated. And I see that repeatedly. We have findings that are going to inform future efforts. And as I mentioned, a health plan can only do so much. In this case, they were totally invested in this project with this group of practitioners, but they couldn't do everything that those practitioners needed. They couldn't provide everything. So there was this need for a third party of some sort to help bring this all together and provide the support that they needed. And that's one of the things that drives adoption, convening communities and supporting them in the ways that they need to be supported. The last thing I wanted to end with was then just shifting over to some of the work with AIM as we've learned from these experiences. We are embarked on a series of initiatives that we call regional integrated transformation zones. The idea of a transformation zone comes from the National Implementation Research Network. And in this, it differentiates horizontal versus vertical efforts. Both are important, but so much of what we've done in pharmacy I view as horizontal across the profession rather than vertically, from payer to medical practitioner to pharmacists to patients, regulatory agencies, all of those matter. And we can't change the whole system at once, but we can take a slice of that system. And what led us to this is this realization that regionalization matters. Our situation in Minnesota is very different in, say, Tennessee, which is another state that we're working in right now. Training has been is different because we're only one school of pharmacy in the state versus having many. There's geography. More than half of the residents of Minnesota live in Minneapolis, St. Paul. The rest live in rural communities. It's very different than a state that maybe has more diversity in the size of communities across its state. The healthcare systems were vertically integrated in Minnesota probably 5 years before that trend really hit most of the country. Performance-based payment systems have been in place for 10, 15 years. All of those things matter when you're doing this type of work. And so this just recognizes some of those variables that we've identified, that what works in one place or how we approach it in one place is different than how we would have to approach it in another place. So while we're waiting for Medicare to change and that to embed pharmacists in Medicare Part B, there is all this opportunity at the local level. And I think we can grow faster if we are working among in regional ways with health plans that are in the commercial marketplace and also with states and their Medicaid programs. And then, of course, those health plans in the Medicare Advantage they have flexibility in Medicare Advantage programs to do some of this work, regardless of what may or may not occur at the CMS level. So this just represents that slice. We can't just talk and work across pharmacy. We have to work in this vertical sense. And there's a method and a discipline that we bring to this. So when we describe a regional transformation zone, it is convening and collaborating among a spectrum of a system stakeholders. What this has looked at, and these are some of the states that we have worked in, you create meetings. In each of these cases, well, not Tennessee yet, we're working towards it. They've been in-person meetings, putting people in the room that have never been in the room together. The health plan leaders, the practice leaders, and we've had medical group leaders, we've had state associations, all having a conversation that they've never had together before to learn from each other, understand each other's pressure points, and coming together to define how do we generate value in this system. And the work of a transformation zone, the role that we play is be the facilitator of those conversations. We don't have all the answers. The community has to come up with its own answers. But in these examples, things have happened that come out of those convenings that wouldn't be there today if there hadn't been that vertical slice of a system coming together and talking through what do we need to accomplish together to improve healthcare in this particular region. So just to conclude, I firmly believe there is tremendous opportunity out there right now, but we have to think with intention and strategically about how we approach this. It is not necessarily easy to adapt a practice for this. And so leaving it to chance is not one that we really have the luxury of letting happen. So how do we take these lessons that we've learned and that we know make a difference and actually apply them so that we are being much more proactive in driving this innovation and the adoption than what maybe we've seen over the last 10 to 15 years. And the last thing I would leave you with is, and I think this is consistent with the center at VCU, is that so much of this really requires regional level convening, and I believe schools of pharmacy, they're not the only ones, but schools of pharmacy are in a great position to be that convener and facilitator across these conversations among the practice community and the health plans. And we've certainly seen that in my state, and it has paid a lot of dividends in terms of how those groups understand each other and the growth of the practice and the patients that are served. So thank you for sharing, or let me share this with you today. I know we have a few minutes left. I am able to stay on a little longer if there is a desire, if people don't need to run right away, but um, hopefully that has painted a kind of a storyline of, at least for my case, where we started and where we're ending and where I hope we're going to go.
Thank you so much for joining. I'll leave some time if there's any questions, either on Zoom or in the classroom.
Hi, Todd. This is Marie Smith from Yukon. Can you hear
Hi,
me?
Marie.
Hey, how are you?
No.
Thank you so much, and thanks for sharing the overview as well as the health partners example. I'm just curious, given where we are with, reaching a tipping point, so to speak, with value-based payment models and contracting. In your discussions, either in Minnesota or in other states, have you seen that as a catalyst or have any experience working with either commercial payers or maybe Medicaid to say that we're seeing some momentum, we have reached the tipping point for getting pharmacy services involved in or integrated with value-based care plan, health plans?
I have not seen it widely adopted. I shared the example for Minnesota. That program's still in place. With health partners, not all the health plans have included a value-based component to it, so it's very health plan specific. Um, what my what I have a bit of a concern on right now is that the more recent strategy to create a payment opportunity has been through a legislative strategy
Yeah,
of payer
yeah.
parity. And I think most of the time, then that becomes a transactional outcome, that it has a fee for service component to it. Without health plan, you must pay pharmacists if you pay other providers for this. And I've not yet seen that necessarily play out to then create a program design on the health plan's part, or that pharmacists are actually advocating for a more strategic approach of partnership, getting to that attribution, looking at population management, directing the services to where you can actually produce the greatest ROI. And instead, it ends up being more of a, here's the codes, you provide the service, we'll pay you. And in some cases, it's not aligning with what health plan priorities are. May not be applying with HEDIS or aligning with HEDIS measures, may not be aligning with STAR measures. So, and for to be brief, I'm not seeing enough of a movement yet, I don't think, on either the plan side or the pharmacy side to advocate for. In addition, you need the cash flow, so the fee for service component is necessary, but to add on to that, then the value-based performance indicators and payment.
Just one quick follow-up. I would just echo and say ditto to everything you just said. There's so many states that have done the right things and have scope of practice, but that scope of practice and regulatory approaches do not automatically, as you said so clearly, translate to implementation and probably more importantly, uptake, So thanks for kind of giving us that perspective.
A quick example, AIM is working with in Tennessee right now. They passed payer parity in 2017. 2025,
Right,
there's very little uptake.
right.
Not even just community pharmacy, in the health systems too. 8 years later, it has not resulted in significant change and therefore very little value achieved by the health plans. Now, part of that's on the health plans too. There's so much inconsistency in program design and in a way in which and pharmacists will call some of the health plans and want to get credentialed, and they'll say, well, we don't credential health plans. Well, 7 years ago, there was a bill passed that said you have to, but it hasn't been managed in a way that can produce on the promise that was originally in the bill, that this could have an impact on the health of Tennesseans. So that's where we're working, trying to make that happen. John, see your hand up.
Yeah. Thank you so much for the presentation. And you kind of answered part of my question. In Virginia, we're doing great with Medicaid and we've had recent regulatory success and starting to expand pharmacy services, getting paid for more services with Medicaid, both at the community pharmacy level and also in the clinic-based setting. We've also had successes a long time ago with commercial legislation, and we're kind of stuck. We haven't really been able to go anywhere with the commercial payment models in Virginia. And so, I guess my question is, how do you get your foot in the door with those commercial payers, and what's like what would maybe be like a first step? We have lots of key stakeholders, I know, but we seem to be kind of stuck.
Well, this is easier said than done, and what worked, I don't know if I would say it's what worked for us. It's part of what happened in Minnesota that led to some of the success. So as we all know, this type of service and where it impacts the health plan and where the home of the program is in the medical benefit, not the pharmacy benefit. The health plans that were the earliest adopters of this hired pharmacists who did not come up through the pharmacy benefit and formulary management and prior authorization and all of that type of strategy to manage a pharmaceutical benefit. They came into those health plans as practitioners. They were residency trained. They had been practicing in most of them in primary care environments, and so they understood that world and they understood the impact of that practice. So easier said than done, but I think that's one of the things that we should be thinking about as a profession is how do we prepare more people to fill that role that have that perspective on the payer side? Because if we are relying on those who have been in a very different world, it doesn't necessarily translate. So we didn't have to externally do much with our health plans because those advocates were on the inside. One of the things that I've done in some of these other states we've worked with is then I get health partners to tell their story to the other health plans and try to help them see peer to peer that this isn't just pharmacy advocating for this and that it isn't the reality. They have the lived experience as a health plan that it produced that ROI. And here's the strategies that we use to make it happen. And so far, they've never said no to anyone who's requested having them share their story to try to help a health plan that is maybe still debating whether or not this is something they want to jump in on or not. So that's one thing that you might consider. And if there's other health plans could do this, but if it was a request of one of ours in Minnesota, I can help create the connection.
Thank you so much.
I'm just going to